Actually, Oliver gave the perfect sort of lead up, because half of the things that he said in his talk were endorsing, including patient-reported outcomes and considerations of quality of life in FDA approval. So thank you. So we'll just review PROs in cancer care as they currently are. I'll address the concept of whether these are soft science. Oliver clearly doesn't think so. I don't think so either, particularly because they affect hard outcomes, which we'll talk about. We'll talk about PROs and how they may be used in treatment decision making, the regulatory response, and some missing links and open questions that I think are prescient, and then I'll just summarize. So the FDA summarizes or says that the patient-reported outcome is any report of the status of a patient's health condition that comes directly from the patient without interpretations of the patient's response by a clinician or anyone else, which is really important because as we consider the alternative, which is CTCAE, that can really be altered by our considerations as clinicians or the research nurse's considerations, and maybe not necessarily the patient's own feeling or actual feeling. And they measure a sense of the patient's sense of well-being and ability to carry out various activities, which we actually don't capture necessarily in the CTCAE at all, how well they can function in their daily life. And we recognized this in prostate cancer many decades ago, I think, with the approval of mitoxantrone, which is really a quality of life improvement approval. Side effects that can be included in an assessment by patient-reported outcomes are pretty varied. It can really assess any non-laboratory or radiographic side effect or complication. There's a CTCAE Pro, which is really a patient-reported CTCAE adapted so that we aren't including necessarily laboratory values. And I would say that PROs are really indispensable for these subjective symptoms that patients have, including pain, depression, anxiety, and fatigue, which can be characterized much better potentially by a patient on a Likert scale than again, a CTCAE scale. It's also useful for assessing the patient's perspective of physical functioning and limitations in their daily lives and interactions, which clearly affect them every single day, not just when they're sitting with you in clinic, and cognitive assessments as well, which are really underrepresented in our prostate cancer population. These are complementary to what we see with the CTCAE. Really, CTCAE has been shown to predict future poor clinical outcomes, but as I said, PROs reflect a daily health status, which really, when put together, reflects what a patient's experiencing. And it was interesting that collecting patient-reported outcomes in clinical practice revealed that up to 50% of symptoms are actually undetected by treatment teams in routine clinical care. So when we're having these patients come in, at least in our clinical evaluations and clinical conversations with them in routine visits, not necessarily in a clinical trial assessment, we're not detecting these things. And this can lead to poor patient satisfaction, declining medication adherence, quality of life that's poor, and disease outcomes that are poor as well. Patient-reported outcomes are actually qualitative data that's quantified. So it's not as soft, I think, as sometimes we believe. They have to be measured by patient-reported outcome measures or PROMs that are validated and reliable in any given population. And we do have multiple PROMs that are valid in patients with prostate cancer. These are brief surveys completed by patients. They describe their symptoms. And if they're collected electronically, they can actually be auto-imported into clinical trial databases or into clinical practice algorithms in the chart. So they can actually be used in just like a vital sign in a clinical visit. I really think that it's important for us to consider that this potentially considered soft science leads to hard outcomes or can affect hard outcomes. So there was a really fascinating study presented at ASCO last year and has been presented in multiple journals since then by Ethan Bosch and his group at Memorial, where they looked at about 760 patients. A third of those were prostate cancer patients who were starting chemotherapy for their metastatic disease. Half of the patients were randomized to routine clinical management of their symptoms during chemotherapy, and half were randomized to complete patient-reported outcome measures between visits. And if these measures met a certain threshold of distress, they were intervened upon between visits. Between clinical visits, the nurses would just call, or social workers, or whoever was necessary. And what was fascinating about this is that there was a decrease in ER visits as well as hospitalizations in the patients who completed these patient-reported outcomes between visits. So if we ask patients how they're doing and then we respond to their distress, we might be able to prevent them from going to the emergency room, which makes a lot of sense, but is not really formalized and structured in our clinical practices at present, and so we're not optimizing this. So what was even more fascinating is that it actually led to improvement in overall survival. So the p-value here is 0.03, and if we look, if we look, we can see that there's about a 4-month benefit in survival because we asked them how they were doing and intervened upon their distress. So this was not because they were getting different chemos. This was really only because we were asking them how we could help. So toxic therapies, as we all know, have been improved on a smaller survival benefit. And I wonder, actually, if the difference between efficacy in a clinical trial and effectiveness that we see in clinical practice might really be driven in part by the fact that our clinical trial patients are getting contacted by our clinic nurses or our research nurses, and we're intervening upon their issues before they have major problems. So how can PROs affect treatment decisions? And I think this is really how I think about how it might affect regulatory practices. Well, if we look at the NCCN guidelines, and these are a little outdated, but not much has changed, at least in the MCRPC setting since in the last few months, we can see that there's just a list here. So how do we make decisions? Well, we can think about patient preferences, we can think about side effect profiles, and we do. We can think about cost, but we also think about quality of life. And so this is just a recent example of a paper that our group worked on for patients with metastatic hormone-sensitive prostate cancer starting chemohormonal therapy versus ADT. And we found that those patients who received chemohormonal therapy actually had an improved quality of life at 12 months. And this is something, quality of life data and other factors that we think about really come into our treatment decisions. When we're thinking about ADT plus ABI or ADT plus chemotherapy, we think about quality of life. We certainly think about cost of care, duration of treatment, et cetera, but this is a component and one that should be measured. If we don't measure it, and if we don't think about it in terms of regulatory decisions, it's not going to affect our treatment decisions. It won't be gathered. I think we had a great discussion on the recent non-metastatic CRPC data, Prosper and Spartan from Oliver, and really patient-reported outcomes were actually presented with the Spartan data up front, simultaneously with the efficacy data, which is not always what we see. It's really fascinating, and these were approved on an MFS endpoint, as we heard, which is both a hard clinical endpoint, or at least hard enough, but also we did hear right away about those patient-reported outcomes. So multiple groups have convened to discuss the utility of incorporating patient-reported outcomes in our oncology practices. One way that we think about making decisions between all of those drugs that we see for MCRPC, for example, is to use comparative effectiveness research, which is really a structured, standardized way to compare therapies that are in different trials, but we need to have the same endpoints for the trials in order to make those comparisons. So a group got together led by Ethan Bosch, who is really a guru in patient-reported outcomes, and they discussed how we could incorporate patient-reported outcome measures in these trial designs so that we could really adequately perform comparative effectiveness research studies in cancer care. So certainly, in order to do so, we need a standardization of our methodology for patient-reported outcome collection. They also suggest that we should release patient-reported outcome data simultaneously with efficacy data. So really our efficacy can be understood within the context of quality of life and vice versa. And this is particularly important in settings in which there are multiple therapies with similar efficacy for asymptomatic and minimally symptomatic patients, so in the non-metastatic CRPC setting, and for patients where duration of therapy is expected to be prolonged, because really these are the things upon which we're relying to make decisions. It's not just how effective is this therapy, but is this therapy worth it when you're on it for 5 years and you're asymptomatic to start. In addition, some recent work from the FDA as well as the Canadian regulatory agencies and European agencies are really suggesting that they are looking at this and they're looking at it hard. So Paul Klutz, who is the head of Deputy Director of Patient Outcomes for the Oncology Center of Excellence at the FDA, worked with regulatory people from Europe and Canada and just published this policy review where they got together to talk about what we need to do in terms of international standardization of patient-reported outcome endpoints for consideration for regulatory approval. Well, what they said was that although specifics vary by country and region, there really is substantial agreement and a lot of work to be done in this space. So integration of PROs into regulatory decisions is necessary for optimizing the patient experience. Everyone agrees with that across the board. But there's really a lack of standardization of patient-reported outcome measure choice and methodology. It really has to be addressed because if it's not similar across studies, we can't compare, and then it's not as valuable as it could be. Particularly if we're putting the effort and the time in, and patient effort and time into this into the work. We have to improve upon poorly performed studies from the past. So in the past, there was sometimes or a fair amount of lack of follow-up for patient-reported outcome measure completion, particularly for patients as they were coming off of studies. And those are probably the patients who are most important to capture in terms of their quality of life. If they're coming off of a drug, we need to understand why, and that data is really critical. And then they also suggest that patient engagement is critical. So the FDA and ASCO are having a convention really to bring in all stakeholders who are interested in June of this year, again, recognizing that patient-reported outcome measures and quality of life is a critical part of the regulatory process, and so they're convening to talk about it. Anyone is welcome. And I would just say, just very briefly, that in patient-reported outcome measures and the CTCAE, we're not necessarily, I don't think, collecting cognitive data as well as we could, particularly in the prostate cancer population. There's a lot of controversy in this setting, and we need a prospective assessment to really figure it out. And then I would also say, just very briefly, that caregivers in prostate cancer specifically may be more sensitive. We may be able to capture more side effects if we actually ask the caregivers as well. There was some nice data by William O that suggests that patients underreport pain by 50%, and if their caregivers participate, that underreporting is significantly reduced. Open questions that I think are out there are which patient-reported outcome domains are most important, and the FDA is certainly grappling with this right now, focusing on functional domains, but considering that others may be important as well. And we need to think about whether there's a way to have simultaneous analysis of efficacy in patient-reported outcome measures when we see the original data, and I think that was just done, so I think it's clearly possible. Luckily, though, the Spartan data came out in that way. How can patients best contribute to the process is something that the FDA continues to grapple with, and if there's a role for caregivers. And then I would say that I think it's important for us to consider whether pharma or other institutions might be able to contribute to our care of patients between visits by helping us to collect patient-reported outcomes between visits, perhaps keeping patients on their drugs longer, and certainly bringing that gap between effectiveness and efficacy potentially to a smaller degree. So to summarize, clinical decision-making could benefit from systematic integration of PRO data into comparative effectiveness studies. We need simultaneous release of PRO data with efficacy, and certainly we need standardization of measures. And regulatory bodies are eager to integrate PROs into their processes, as is evidenced by their multiple publications and the meetings that they're holding to discuss this. The methodology really needs to be standardized. Assessments must be tailored to the population and disease state, and patients actually have to be very integrated and involved in the process to make sure we're measuring what's most important to them. Thank you.
Questions? Thank you.
Yeah. Where do you think wearable technology will fit into the PRO data?
So that was actually discussed in the paper that the simultaneous report from Lancet Oncology with the FDA, Canada, and Europe. The United States is very eager to integrate that, and I think that the nice thing about that, and what's important to me in my work too, is really taking what people think is this soft science and showing objective physiologic factors that might be associated with it. I think it really strengthens the patient-reported outcome measure and helps even critics understand that there may be physiologic processes that are supporting the complaint. So I think that it's becoming feasible because we have the technology and we're moving in that direction. The FDA is very interested in incorporating it.
Alicia, so mitoxantrone was approved by the FDA, I don't know when, many years ago, before, thank you, 1996, under some pressure to approve something, and they did it on the basis of quality of life improvements without a survival benefit. Gemcitabine had the same in pancreas cancer, but those were both in situations where there was nothing that worked. So do you think that PROs are actually going to lead to the approval of drugs that don't have efficacy benefits in the future? Is that where the FDA is going to go with this?
So it depends on how you define benefit, but I would say I doubt it. I think we all doubt it. I think you doubt it by the way you asked the question. But I think
just trying to be controversial.
Yeah, no, it's good. That was my charge from John, raise controversy. So I think that it's complementary. I think we need to interpret efficacy data in the context of the way that it makes our patients feel. And if we don't ask them and allow them to report to us how they feel, we won't have that information. So it really is quite complementary. I don't think there are many clinical spaces in prostate cancer where the need is so great for us to intervene that we need to have a drug approved on quality of life improvement alone, but who knows?
I'd like to kind of comment a little bit. In all honesty, let's say you took it to extreme. You said, here I have a patient and there's no survival advantage, but they feel great the whole time. I would say, yeah, I would approve that drug. Now the question
I think
is,
it's called
what you
heroin.
price it? What? It's Xanax. It's actually Xanax.
Xanax.
Homeopathy.
So, but I mean, I think you could do it, but again, it's pricing and everything. And you do it the same thing for some of the survival. I would say I would want a drug that made somebody feel better while they're on the therapy. The second thing though, I just want to comment on, when you look at it, and you brought up kind of the point is the patient when they're doing it, because again, a lot of times they've reported that patients will not tell the doctor what's wrong with them because they worry the doctor will stop the therapy, and they worry that therapy is all that's going to get them through it. So kind of in between, I think it makes a lot of sense that in between times that they could do something, especially on a smartphone or something, to make that sense. But it's also who's doing it. Have they looked at man versus woman in terms of reporting patient, or obviously for prostate cancer it's all men, but the difference. And then again, how many of us have had the wife say, he says he's feeling great, but here I got the list of things that's wrong with it, and probably reality somewhere in between the two. So is there a way to start kind of characterizing all those things to get the best true estimate of what's happening with that patient?
Yeah, it's so interesting. The truth is really such a compilation of so many opinions. So I would imagine in Ethan's data, he could break out, I think there were breast cancer patients as well. So a third were prostate, and then I think colorectal and breast. So he could probably pull out some gender differences. I have not seen good data on caregiver report, but the reason I put it in there is because that's exactly what happens in my clinic. And then the patient actually will agree with it, but it has to be brought up by someone else first. And there are many reasons why I think that happens. So I'm in the process of working on developing a concept through one of the cooperative groups that is a patient-reported outcome study looking at some of these relevant clinical outcomes, not necessarily survival. I don't know if we can get that big, but we'll see. But in any event, there's a caregiver component because I think it just needs to be studied. I don't know where the truth is going to be, but I think we have to collect the data and try to sort that out.
Correlates closest, or is it a amalgam of the two?
With clinical outcomes, exactly.
So
Sort of in line with that, we have a pretty decent understanding of baseline characteristics that lead to heterogeneity and efficacy outcomes, and we stratify for those. But how much do we understand about differences, individualized differences in experience in reporting, to be able to make sure that we're balancing patients well in randomized studies if this is going to be a primary endpoint?
So I agree. At this point, within our current efficacy studies, we randomize. And so then if your population is large enough, you would assume that you're going to get a random, just because, you apply the therapy on top of this randomization. So I think that the hope is at least that we are diluting that through our randomization process, but it absolutely could be an issue. There's also an issue, actually Chuck and I work on or developing some ideas around the biologic basis, not necessarily of just how one reports, but how one experiences therapy. So there's probably biology, there's probably genetic differences that are driving people's different experiences. And I think many of us have heard of the placebo gene, which is potentially playing a role in how these patients are feeling and acting. And should we be incorporating genetics in our initial randomization? Or thinking about it as a stratification factor. So I think it's much more complex than just efficacy. And there could be some of these things driving, particularly studies that are very close in terms of their benefit or their lack of benefit. There may be other factors coming into play.
Alicia, are there any apps that are being developed or you think have utility in accurate reporting? Because many a time when patients come, they don't, they may be wanting to tell us the symptoms, but then they can't remember, and especially if they're alone. So have you thought of any patient-friendly apps in this scenario?
So there's a company in San Francisco that's started developing an app and then sort of backed off of it. I'm certain that there are apps being developed. I know that Northwestern has, I don't think they've necessarily progressed to an app, but they have a really nice computer system that they're using for clinical practice that I'm hoping to utilize in cooperative group studies, sort of expanding it. But I would say that's a gap, and I am not a computer expert. I barely have apps that function on my own phone. So, but I think that there's a need, because something very simple with big print that people can feel comfortable with at home when they're experiencing the problem is exactly the way that we want to understand their concerns.
Yeah, through a friend, I know that Hopkins is developing a program now in their neurology department to enroll 20,000 patients around the country with Parkinson's disease into a reporting system through an app. And it's a big undertaking, but they're started. My question was, was there quality of life data collected in the intermittent androgen deprivation versus continuous androgen deprivation study? And were there much significant differences?
So others can certainly comment on this too. There were. I'm not sure which measures that they used, but I do know that the quality of life measures appeared to be sort of dissimilar at 3 months. But as time went on, the quality of life seemed to sort of come back together, intermittent versus continuous. There was not a sustained difference. I'm not sure if others who were involved in those studies know which measures were used. I certainly, we could talk through it later, but I don't know them offhand.
Alicia, I was just going to point out that the regulators around the world differ, and the European regulators are much more attuned to the patient-reported outcomes and to help build in quality adjusted life years, et cetera, that are not present in typical data. And in this sort of global environment we're currently in, everybody wants Western Europe in addition to the U.S. So it's just one more reason.
Agreed. So outlined very clearly in that Lancet Oncology paper is the experience of the Europeans, and they have citation after citation. They have meetings regularly to discuss optimal methods. The FDA's standpoint is still very much, it's a work in progress. We have overall survival MFS, but I think we're moving in the direction, and the fact that they collaborated on a single paper, to me at least, suggests that they're willing to think about it together.
Great, important topic. Thank you, Alicia. So the next study we're going to